Thanks. Hi, everybody. Might just wait for another minute because we're expecting up to 30 people, so there might be a couple of stragglers because you're also desperate to get here, and thank you. In the meantime, welcome to the second installation of the Connecting, Coaching and Changing Lives program tonight, which will have obviously the educational webinar and the lovely peer education section. Just for those, just for a reminder, obviously the first section, educational webinar, is open to everybody, but those that are not part of the actual CCC, the Connecting, Coaching and Changing Lives program, will be asked to leave during that second part, which will be after the Q&A on this section. So I will ask you to stay muted. If you could all mute yourselves, that would be great. Just so we don't have any little dogs coming on or barking, or cats or children. Scott, can you mute yourself? If you're not, Sarah, can you mute yourself? Cheryl, if you're not muted. Are you muted, Sarah? Scott Aitken, are you muted? You just shake your head or...
Darren, I'll just mute everybody, okay?
Okay. All right, I have to unmute. All right. Look, we might get going. I suppose we'll probably get a couple of stragglers come in. As I said, welcome. As I said, can everybody please mute themselves? Hence.
Sorry, Darren, I muted you when I muted all.
Don't you love technology? Oh, we're all loving all these Zooms and Skypes and Teams, and anyway, nothing's perfect. Let's move on. So once again, thank you, and welcome to the second edition of the 6-part series of the CCC program and the educational webinar. So let's move on. Next slide, please, Linda. Okay, allow me just to do an acknowledgement of country here. So as we gather for this meeting, physically dispersed and virtually constructed, let us take a moment to reflect the meaning of place. In doing so, recognise the various traditional lands on which we do our business today. We acknowledge the elders past, present and emerging of all the land we work and live on, and their ancestral spirits, with gratitude and respect. Next slide, please, Linda. Okay, so as we said, this is part A. We're moving now into the educational webinar section. Next slide, please, Linda. Okay, so we'll kick off shortly. So this month, I should say, we are covering the topic of benzodiazepines. Allow me to introduce the layout of the day, which was similar to last time. Lucinda is our clinical expert, who I will introduce to you very shortly, who will provide the presentation on benzodiazepines, half an hour, followed by a Q&A session. If you would like to ask a question, please use the chat button at the bottom that you can see there. There's a message already in there, which I think is from Jason. And I will ask Jason, Lan and Michelle, the nurse practitioners, the mentors, if you could answer some of the questions that do come up. So please feel free to ask as many questions. If they're not addressed during the actual webinar itself, we will be, and also posing some to Lucinda later on. By all means, we'll have a 10-minute. Then we'll break for 5 minutes where other people will be leaving that are not part of the CCC program. And then we'll be coming back to section B, which we will be discussing the alcohol case study, and Jason will be leading that. So without further ado, allow me to introduce Lucinda Scopoletti, an alcohol and other drug nurse practitioner for many years. Lucinda Scopolotti has been nursing since 1995 and with over 22 years experience in the drug and alcohol field. Her breadth of experience in drug and alcohol includes inpatient and outpatient withdrawal management in the hospital, community and correctional settings. Her roles have included withdrawal management, nurse unit manager of an inpatient outpatient withdrawal service, opioid treatment program, and blood-borne virus screening and treatment in hospital consultation liaison. She is currently working as a nurse practitioner in private practice and as a clinical nurse consultant at St Vincent's Hospital in Sydney. Her expertise and reputation enables her to represent drug and alcohol nurses at a local, state, and national level, and she is an executive member of the Drug and Alcohol Nurses of Australasia. Next slide, please, and over to you, Lucinda. Thank you.
Good evening and welcome to everybody. I'd just like to say tonight we're going to be talking about benzodiazepines, benzodiazepine withdrawal and use disorders, predominantly about how to screen for benzodiazepine use, how to do a comprehensive assessment, how to manage withdrawal, how to recognise withdrawal and manage withdrawal, the treatments that we do use and the medications that we do use for these patients. Next slide, please, Linda. So, no, next one, sorry. We've already done that. So benzodiazepines, and I'll refer to them as BZD from now on in the slides. And I don't talk much about the Z drugs, so the ones like Zolpidem, they do have a similar effect and very similar profile and withdrawal effects. So we'll include them as if they are part of this talk as well. So they're a sedative, hypnotic and anxiolytic medication. They're a central nervous system depressant. They act on the inhibitory neurotransmitter GABA-A. They're S4 and recently in 2014 S8 drugs, so do need to be scripted and an authority for the S8 components, the medications that are S8. Some of the things that are most concerning about benzodiazepines and why some of them were upregulated were the number of deaths. So 3.3 per 100,000 drug-induced deaths are can be identified, benzodiazepines are identified in these patients at autopsy. Benzodiazepines and opioids directly attributable and contributing to these deaths. So often in combination, not in isolation. And I think this will lead us to looking at why such a thorough assessment and careful management of these patients is so important. 3.2% of hospitalisations in Australia are benzodiazepine are included in the presentation somewhere in the history taking and cause, or do end up being discovered in the presentation, which is actually coming down since 2015. Is that because of the upregulation of one of the major ones, which was Alprazolam? Don't really know, but we do know that there's a lot of increase in black market medications now from overseas, and they may end up being more of a trend upwards, hopefully not in the future, but maybe. Next slide, please. So the indications to give patients benzodiazepines when they're prescribed are for generalised anxiety disorder. This has been around since the 1940s, 50s, where they were often called mother's little helper. Mums were anxious, they were home, stressed, not working, lots of kids, had to have the house in order for dad when he got home. And it was prescribed often in those circumstances. Even today, a lot of patients are prescribed diazepam for anxiety, and they do continue to be prescribed for months and years. A lot of the patients I have met have been prescribed for over 10 years and started off as an anxiety treatment. And we now know today that it's such a dependent causing medication that it isn't the right treatment anymore. Panic disorder, psychiatrists have been using it for many years. Seizure disorders, a lot of patients will come in and say they're using flunitrazepam. That's one of their medication for their seizure disorder. It is a secondary medication for some disorders, but it's not a first-line treatment for a seizure disorder, whether it's epilepsy or from another cause. Insomnia, so using diazepam and other medications, temazepam, Mobidon, to get nitrazepam to get to sleep can be problematic and can start building up over years and get intolerance. For muscular disorders, musculoskeletal disorders, for back pain, for a range of conditions, it's also prescribed for those as well. And some of these are where our patients get in trouble and do have ongoing prescribing, and then they turn up in our services. Next slide, please. So we swallow our benzodiazepines, and formerly a lot of injecting, but benzodiazepine use used to happen. So I don't see a lot of that now. Some of our panel might be able to talk a bit more about that. Some of the other nurses on board tonight, how much they're seeing of benzos being injected, but I don't see much anymore at all. So they go in conjugated and they're excreted in the urine. It goes through an added, they're hydroxylized, so the hydrogen added to them, and then they're gluconated, which means they get a water-soluble molecule added, and then they're excreted in the urine, and that's where we often find our urine drug screen results so helpful. Varying half-life, so you get a quicker onset for some medications. Some of these ones, some of them can last for 12, 24 hours, some for many days. The half-life varies quite broadly. And that would also depend on the liver status. So if you have a patient with cirrhosis or a fatty liver, and maybe in conjunction with alcohol use disorder, you don't know how long that drug is going to take to metabolize. So one of the things we do want to do, and we'll talk about that more when we're doing our assessment, is you want to check their blood-borne virus status. You want to see, is there another treatment that we can do while we're treating a benzodiazepine dependence? We can actually treat a blood-borne virus as well. So really good part of our assessment when we have a look. So in saying that, when we're looking at urine drug screen results in hospital or when we're taking them for ourselves in the clinics or community, we have to be very careful about what we're looking at. Is it the parent drug? Is it one of the metabolites? So that's what we'll talk about a bit later as well. Next slide, please. So this is, hopefully this is clear enough for you. So this is the benzodiazepine equivalent. So when you're looking at the onset of the drug's effect and then the onset of withdrawal, we're looking at how long of an acting drug they are. The shorter the acting drug, the quicker the withdrawal will start. Diazepam is what we use for withdrawal management because it is one of the longer acting medications. And I think the top drug, Alprazolam, is one of the ones that got up-regulated because it was so problematic. When I did work in the prisons, I had a lot of patients would tell me there's a lagan, which is a prison intern, in every pill because it's just so, you don't know what you're doing, you don't have the memory of what was happening when you've taken one or two or three, and so much harm was coming. That's why it was upregulated to an S8. So if you have a look at all the different half-lives there, I've got all of these. This one's from South Australia. It's a really good equivalent table. All of these will be accessible later. You can get the slides and get all these references, so don't focus too much on this at the moment. As you can see, one of the Z drugs there down the bottom is Zolpidem, very short-acting, 10 milligram tablets. A lot of GPs are prescribing this, not realising that it's can be as dependent forming as the regular benzodiazepine. So next slide, please. Now all the different sources that we can get our benzos from. So iatrogenic, sometimes our patients are coming into hospital and getting their benzos started. I'm anxious, I need something to sleep. I usually take this much. Doctors don't check in hospital often with GPs. They're very busy. They've got around 50 patients. They'll just prescribe what is needed. The patient's still in hospital 3 months later and they have a dependence. They have developed a tolerance. They may not be needing more and more to get the same effect, but they actually have a physical dependence. So do they meet the criteria for dependence in the DSM-5 or the ICD-11? No, but they physically may have a withdrawal from that medication. GPs are definitely prescribing benzodiazepines, and there's a new trick in New South Wales and other states now to help that out, called SafeScript. We'll talk about that. Psychiatrists, notoriously, patients that I see are often started many years ago on benzodiazepines for anxiety, and that's when they become, they're not treating the actual cause of anxiety, they're treating the symptoms. Short term, 2 or 3 weeks is reasonable, but not any longer, and that's where we're finding a lot of our patients are coming unstuck. You get it from friends, you might get grandma's diazepam next door, you might get, you can get it from anywhere. Black market. I knew a family that lived in one of the suburbs of Sydney that they told me that you could back a truck up to a factory in one of the suburbs and they would load you up with all the boxes of medications, black market medications. So you didn't even need a script. And it wasn't coming straight out of a pharmacy, it was coming straight from the suppliers. And the overseas market as well. A lot of patients may be going overseas to Fiji. You can get a lot of benzodiazepines in Fiji. We don't know what's in them, but they're coming back with these, what they're saying are diazepam. They don't know what they are. We don't know the strength or the onset. It's a minefield when you're using these medications. So when you're doing history taking, you've got to really dig down and find out where they're getting them from and what their branding's like and have a look at them. Next slide, please. To prescribe these 2 medications, you need an authority. So this is just a quick example in New South Wales of what an authority looks like that you need to gain. I can't think of any reason I would be ever doing this as a nurse practitioner in drug and alcohol. I think this is what something you might be seeing a psychiatrist doing to prescribe these medications, but I can never see any reason to be doing this. And I don't know if any of our other panel members or experts would be agreeing with me. Next slide, please. Just another statistic on from the National Drug Strategy Household Survey about how many people are using these medications in a non-medical use, and it's increasing. As you can see from 2001, and it's gone up to 4.9% in 2019 for tranquilizers, and these are all benzodiazepines are included in these numbers. They're not just purely benzodiazepines. So you can see the use of these is actually on the rise. Next slide, please. And causes of death in Australia, as you can see, opioids are causes of death from different drug classes. Opioids are the highest, and the second highest are the depressants, and that is including the benzodiazepines. So they are a real problem, and they are used in conjunction with opioids mostly. Part of our assessment will cover that and all the other different screening we have to do to treat these guys well and get them sorted. Next slide, please. So any patient that comes into our services or past our door, we need to be screening for all their illicit drug use, alcohol use, prescribed medications. If you ask a patient what other drugs do you use, they may not consider that their benzodiazepine use is a drug. If they don't see it as a problem, they may not even tell you about it. So you have to really dig deep down and find out what sort of symptoms that they're getting, what medications they're taking, and what effects do they get from them, and then the benzodiazepines may come up. looking at what quantity and frequency they are using. There are a lot of different screening tools in different hospitals, different states. So look in your hospital or in your state, in your withdrawal guidelines or in your drug and alcohol guidelines for what screening tools that they recommend. And it should be on entry. It shouldn't be something that comes out later, because what you might be doing for someone who's having an alcohol withdrawal could be that you're giving someone who's codependent benzodiazepines. They may be using Valium to help themselves with their alcohol use, and you're already giving them diazepam for their alcohol withdrawal, and you're actually treating two things at once and you don't know. And the withdrawal symptoms will be a lot more severe and unexpected. Next slide, please. And this is the slide that Stephen Ling had last when we met, and I've pinched that. It's the dependence criteria, and this is where our comprehensive assessment is looking at all these factors. And I might have to come back to this slide a little bit, Linda, to cover how well we have to screen and then how well we have to assess what our patients are actually doing. So the dependence criteria, I think you all know, this is pretty basic starting drug and alcohol nursing, what you need to know. It can be the DSM-5 and it can be ICD-10. As you see, the items written in black are the main items. Within the last 12 months, if you have any of these symptoms or criteria, that will tell us how dependent you are. And severity dependence or dependent, or just using them and not actually having any problem with them. You might be having one every week and that's not an issue. So, for example, you might have a lady come into hospital who says she's using diazepam. She might have 5 milligram tablets. She's had a box for a year and she takes it at night once a week. And last week she took 2 tablets and had a fall. She got a bit sloppy and had a fall. You know, she wouldn't meet the criteria of dependent. She's not using it a lot. She's not using more amounts. She doesn't have withdrawal because she's only using it once a week. Has she had a bad effect from having too many? Yes, but she doesn't actually meet any criteria. She hasn't got a physical dependence. She hasn't got problematic use of it one time, doesn't meet this criteria. So next slide, please, and we'll talk a bit more about how important an assessment is. I've put in the red, I've put which ones I think are the main things that we have to talk about to do a comprehensive assessment. So we need to know what the name of the drug is that they're using or what they're calling it. You need to know what type of medication it is, how long acting it is, because that will give you an idea of when withdrawal might start. How many milligrams per day? So we need to be calculating how many total milligrams per day they're having. When you meet a patient who is benzodependent, heavily dependent, there's not a lot of, the history might be very vague because they can't remember a lot. It's very difficult to go back weeks and months and years. So you do have to be patient when you're taking that history, because it will be very important knowing exactly how many milligrams per day, how many days per week, how many days per month maybe, and looking at periods of abstinence will give you an idea of is there any break and what happens when they have that break. It only takes, I think, between 3 and 6 weeks of regular, at least 20 milligrams a day of diazepam equivalent to become physically tolerant and maybe having a withdrawal risk. So it's not very long. Like alcohol could take a year or 2 more. Heroin, of course, opioids are short as well. And benzodiazepines, unfortunately, can be just in a few weeks. And that would also, wouldn't be 2 milligrams of diazepam, probably wouldn't get that effect. If you're taking more and more and taking decent amounts, you can have a withdrawal effect within a few weeks. It wouldn't be as severe as someone who's taking very large doses for many years, but there is still a withdrawal syndrome likely. And history of overdose tells you also that patients are using these in a problematic way. It might lead you to looking at more at their mental health history as well. The last 30 days isn't a good indication of if they are dependent, but it does help you know if there is going to be withdrawal syndrome imminently. And an imminent withdrawal syndrome doesn't tell you someone is physically dependent or not. Physical dependence, or sorry, that physical dependence it would do, but in the whole concept of being drug dependent, it doesn't tell you everything. They may have had 11 months of using benzos daily and had a quick withdrawal and then relapsed again or overdosed, and for the last 30 days doesn't give you a great idea. Their treatment history is very important, knowing when they have sought treatment or have they not. Have they had outpatient or inpatient treatment before? We need to know when they had those treatments, what actually happened. Did they get withdrawal symptoms when they stopped using? If they stop using on their own, what happens? Like, how many days can you go without this medication, and how do you feel? The most severe withdrawal symptoms, of course, is seizures and delirium. And these are GABA and glutamate mediated. These neurotransmitter sites do get the changes that can cause these symptoms. So the delirium and the seizures are not uncommon. They're not rare. They're not common, but they're not rare either. And there's something to be watching out for when a patient's coming in. And they can come in withdrawal and still have a benzodiazepine in their urine. So we don't always know. And I think taking a history of a benzodiazepine dependent patient is like putting your Sherlock Holmes hat on. It's quite difficult, quite interesting. You do a lot of homework and trying to find out what's actually going on. And the drug type will also tell you when the withdrawal onset might start. So the shorter acting benzodiazepines will start, their withdrawal might start quicker. So you might be seeing something in 2 days. Other benzodiazepines you might be taking 3 days, 4 days before they'll start having symptoms. Next slide, please. The dependence criteria, we need to look at all their developmental history as well. Now, these are very important because you want to find out when you're treating someone for benzodiazepine dependence, you want to get the drug withdrawal over. But you also want to find out what's actually causing their drug use in the first place. When did it start? Why did it start? What does it do for them? Socially, we need to know where they're living. Are they homeless? Do they have someone supporting them? Do they have a job? Are they employed? Medically and surgically, did they actually get their dependence while they were in hospital? This is something that started from an operation where they were really nervous. They may have had cancer and had to have benzo for anxiety because they were so anxious about their disorder. Psychologically, again, we need to know their psychological history, their self-harm history, suicide, and when their anxiety started. And legally, have they been in trouble with the law because of their benzodiazepine use? Have they had jail terms related to their drug use or drug dealing? It's all relevant when you come to look at dependence criteria. All these things will add up to, are they using when they shouldn't be? Are they having a strong craving to keep using, knowing the harms, and they're still using despite that? So this is all the part that tells you how well entrenched they are in their benzo use. Next slide, please. So also physical exam, we've got to look at concurrent illness when you're going to treat someone. We need to look at other venipuncture marks if they're using other drugs as well, because benzos and opioids do go together very commonly, so do benzos and stimulants. They'll have a stimulant use and then maybe they will use a benzo to come down off that, or an opioid to come down off their stimulant high. So be very wary of that. The most important thing is to go into your to GPs, have a chat with their GP, get a health summary, find out what they've been prescribing, look at EMR, look for other discharge summaries that might mention benzo use, look at HealthyNet. And most often, golden in New South Wales is now what we call SafeScript, which is real-time monitoring of benzo, or not benzos, but it includes benzodiazepine prescribing and dispensing. That tells you the GP's name and the dispensing point, so the pharmacy. And you can ring this prescription shopping hotline, which is think it's a countrywide, it's Medicare, and they can tell you how many scripts have come out under how many prescribers if the patient meets the set criteria for that hotline. So that's very good as well.
5 minutes, Lucinda.
Thanks. Got to consider specialist consultation if you've got real safety concerns for these patients. I think as an NP, we're pretty good at doing most things, but I think as we know, if you're working privately, you need to have a collaborative agreement. If you're not working privately, I still think it's good to have a staff specialist on board if you really find a really problematic patient, very, very complex with other drug concerns, psychological safety concerns, major mental health illness. You really need to have some support. I think I find it very helpful. And I think a big part of doing a benzo withdrawal inpatient is another quick slide coming up, but inpatient is very stabilising, then coming on as an outpatient later if they have long-term use, and be really wary that you're not going to become another prescriber if you're working privately. Next slide, please. So this is a quick example of safe script in New South Wales that I had a patient as a private patient, and I did a quick safe script check on her. She told me she hadn't used any benzodiazepines. Here's my my check on her. She'd had some in 2011, 21 in November, and then the next script we gave her was for her alcohol withdrawal. And I saw that she didn't have any other diazepam dispensed, so that was I felt quite safe doing that with her. I also had to go and check on this because she told me she did actually go back to the GP after our letter to the GP saying we were doing withdrawal. She got a box of 50 diazepam for her dog because she said the vet charged too much. So she actually, I checked on this today, she actually hadn't got that script dispensed yet. So that's really good. So I can have a chat with her when I see her about that. And a chat with the GP to say, we told you we're doing a detox while you're giving her 50 more Valium. So. And next slide, please. I've only got about 3 minutes to go. So benzo intoxication, I think you can all Google that one. We know that they look really sloppy, they fall over, they get, at the worst, they can get really, with other drug use, they can get respiratory compromise and death from that. Next slide, please. Tolerance and dependence, we know that there needs to be neuroadaptation. The receptors need to be changing and adapting glutamate and GABA-A to make these changes, make the patients need more and more to get to a harmful amount, and it takes at least 3 weeks, like we said before. Next slide, please. The tolerance and the long-term effects is there is a little bit of evidence for some cognitive decline. It's not huge, but really these are the effects of long-term benzo use. This is from one of our New South Wales health websites, Your Room, and I'll have that as well for you to use. You can have a look at many, many different drugs in that website. Next slide, please. When you're assessing your patient, you really need to do a urine drug screen. One of the clinics in Sydney is also using not diazepam anymore to do their withdrawals. They're using a different benzo because it doesn't metabolize like diazepam, and they can tell if they're using extra benzos. So it's quite clever. I think it was clobazam, but maybe it's not. I'll have to check and let you know when we do our next session. Checking all their UECs, make sure they haven't had a long line, check their CK, liver function tests, make sure there's no concurrent alcohol use. As I said before, there's lots of use of opioids and injecting drug use, so check, make sure you're doing a bloodborne virus screen. Might give you an opportunity to treat them if they have hepatitis C, because we know this is a huge group that do carry hep C and do share it around. Next slide, please. The withdrawal, psychological and physical, as I said, the worst withdrawal is seizures and delirium. I've seen many, many delirium, some of them almost like patients catatonic, others are shaking violently, sometimes very similar to alcohol withdrawal, but much more psychologically affecting with their symptoms. You get lots of twitching, not so much a tremor, but just these funny twitches in their face. You might get them in your hands. It's quite distinct from alcohol withdrawal, but in other words, another way it's very similar as well. Next slide. So the goal of management is to have severe withdrawal prevented. More than 50 milligrams of diazepam a day is going to give you some risk of withdrawal that needs ongoing management, hallucinations and delirium. We want to stop people falling over. We want to stop them dying. Treating concurrent medical conditions as well that mimic withdrawal. Be wary of other medical conditions. That's why you need a health summary from the GP and bloods. And the patient needs to be really involved in their pain, or you're not going to get any sense of control from them. They're going to think, you're running this and I'm not doing it. So getting them on board. Next slide. Inpatient versus outpatient. You cannot treat an outpatient who doesn't have a responsible person with them, who has an acute mental health illness, a concurrent dependence on another drug, complicated withdrawal. So if they've got a history of seizures or delirium, you cannot start a benzo withdrawal in the community. You might be able to finish it once they've got to a stable dose, but definitely not starting it. Homelessness, yeah, it'd be very difficult. And repeated attempts at outpatient withdrawal management should not be attempted again. You should be settling them down on a decent dose in hospital and then out to the community. Next slide, please. So long-acting benzos are what we use. We convert the dose equivalent to about 40–50% of what they report. And then we give divided doses. So it could be QID, TDS, BD. I'd probably start with TDS. Reducing it by 10–15% every 3 days as they tolerate. You might end up going up and down a little bit. If you're doing a 3–4 month withdrawal, they might have a death in the family. They need to stabilise for a week or two and then you go down again. Stage supply only at a pharmacy where you're getting a regular update from the pharmacist, how they're appearing and how they're attending. And you probably need to be seeing them weekly. I wouldn't be doing any less than weekly visits. Probably more than weekly in the beginning. All the usual things, do not drive. Benzo withdrawal chart, you can Google them and find them if it helps you keep a track of symptoms. And get family to assist with monitoring if you can. Getting family on board is very important. They'll be able to tell you a lot more than what you might be able to see. It's happening outside the weekly or twice weekly visits. Next slide, please.
Cindy, you've got 2 minutes to wrap up before we'll finish.
Okay. We've got the usual treatments for all of our drug use disorders: smart recovery, the counselling, CBT, residential rehab, family support is very, very important. If they have a psychological history, anxiety disorder of any type, I think considering some antidepressants or the SSRIs that do help with anxiety. And psychology, psychiatrists maybe, but trauma-informed people that understand why this person may have actually started using benzodiazepines in the first place. I think it's really, I think, has everyone heard of ACEs, the adverse childhood experiences? A lot of that is involved in a lot of these patients' histories from childhood and young adulthood, and that's why they're using them to curb their anxiety. Next slide, please. This is from the RACGP website. Really, really good one to give you an idea of how much withdrawal management might need, duration of use, and then what sort of treatment they might need and how quickly you need to do it. I know when I worked in prison, if they came in, it wouldn't matter how long you've been using, 5 days and you were off. If they had a seizure, we took them to hospital. As outpatient NPs, I don't think we're going to be that cruel. So this is a really good one to give you an idea of if they've been using for more than a year, you might take 2 or 3 months. If it's only been a few weeks, you could do it quite quickly or not even do it at all. So that's a really good one that you can keep to monitor and give yourself a guide on after you've done your assessment. Next slide. Yeah, just treat other symptomatic symptoms as you would for any illness. Also in vomiting, antiemetics, headaches, paracetamol, ibuprofen. Check the liver again, make sure you're not going to give them too much paracetamol. Next slide, please. And they're all my references. So I'm sorry I have to talk really quick. There's so much to talk about. I hope we do a case study in a few weeks and we can talk more and talk about individual problems that you've had with benzos.
Thanks, Lucinda. Thank you.
Thank you.
Thank you for that great